pyrexia of unknown origin. It's a fairly basic topic for most of the registrars who have joined, but I thought I might give you some insights as to how to approach it rationally. So in this lecture, there are two parts to this lecture. So the part one will be talking about certain definitions of pyrexia of unknown origin. We'll look at certain etiologies, as well as we'll discuss about a rational approach to the presentation. Then in part two, I will be presenting a case, and based on that, I'll be doing the rest of the presentation. All right, so we'll start with the basics. So the first thing is, what is fever? So fever is defined as core body temperature of at least 38 degrees. So in Fahrenheit, so that is Celsius. In Fahrenheit, it's going to be 100.4. There are certain textbooks which I have seen where they describe it depending on the time of the day. The reason why they describe it in that fashion is because, as you know, the body temperature changes with the time of the day. So for example, early in the morning, the body temperature is slightly low, and towards the afternoon around 2 to 4 o'clock, the temperature is about 1 Celsius higher than what was in the morning. So certain books describe fever as more than 99 Fahrenheit in the morning and more than 100 in the afternoon. And the core body temperature changes with lots of parameters. I mean, changes with the age, sex, and especially in ladies, it changes with the menstrual cycle, the activity level. So lots of factors that can affect the body temperature. And as you know, infants, the temperature is slightly higher because they have a higher body surface to weight ratio, as well as their metabolism is fairly high. But the most textbooks kind of have agreed upon that the core body temperature of at least 38 degrees can be considered as fever. So we need to know a little bit about the physiology of fever as well. I wouldn't go into details, but as you know, the temperature is regulated by the hypothalamus. There are two main organs that control the temperature, that is the lung and the skin, as well as the metabolic rate. So with all these factors, the body temperature is maintained within the normal range. There are two terms that we should be familiar with. One is FWS, that is fever without source. Sometimes it is described as fever without focus, versus FOU, that is fever of unknown origin. So what's the difference? So fever without source or fever without focus is you have fever, but you can't find a focus. I mean, the cultures are negative. When you do a thorough examination, you can't find the cause for the fever. So in those sort of instances, we label them as fever without source. Most of them are actually viral infections. But if you can't find a cause for the fever without source within a period of 1 week, then it becomes fever of unknown origin or pyrexia of unknown origin. Dinakshita?
Yes, sir.
No, I lost control. I mean, for some reason, I couldn't control the presentation. Okay, fine. I think I have control again. Right. Okay.
Yeah.
So, what is the definition of pyrexia of unknown origin? I mean, if you look at the literature, I mean, maybe 50 years ago, the first definition that we can find in textbooks introduced by these two gentlemen, that was fever, that is temperature, core body temperature of more than 38 Celsius, persisting without a diagnosis for at least 3 weeks. So this was the definition 50 years ago, or maybe 60 years actually. But now, as you know, the technology is different. We have so many diagnostic methods coming. So we don't wait 3 weeks to diagnose pyrexia or to label a patient as pyrexia of unknown origin. Now the Dinakshita, sorry, Dinakshita. No, I'm getting
Yeah,
lots
I
of
can hear you,
messages
sir.
saying that somebody is waiting in the lobby. It's a bit
No, so
disturbing.
don't worry, sir. I'm
Okay,
at.
right.
Oh,
Okay, you are controlling
I'm
that, no?
admitting them. Don't worry, sir.
All right.
Yeah,
Okay.
we not see it in the screen. Don't worry, sir.
Okay, excellent. Right. Okay, sorry about that because I'm getting some messages through my Microsoft Teams. Okay, so now the current definition, as I said, with the development of the technology, we have brought down the duration of pyrexia of unknown origin to at least 1 week. So it has come down from 3 weeks to 1 week, and this 1 week of temperature or fever could be the patient could be in the hospital or it could be in the outpatient department, provided that the outpatient department is carrying out methodical investigation and evaluation. There are a few categories that we should be aware of that is inside this broad umbrella term of pyrexia of unknown origin. Those are nosocomial PUO, neutropenic PUO, and HIV-associated PUO. Why we have introduced these subcategories is because the organisms that we are dealing with in these sort of scenarios are totally different from what you would see in any other in normal circumstances. For example, so if it is nosocomial PUO, the organisms can be things that we would find in the hospital like MRSAs or Clostridium difficile or even drugs. And certain catheters or cannulas which are in situ also can give rise to fever. So we are thinking, the types of organisms that we are thinking are quite different. Then we have for example, in neutropenic PUO, we are thinking of So in neutropenic PUO, we are thinking of opportunistic organisms such as certain bacteria, viruses such as CMV. Then in HIV, as you know, they are more prone to get infections from pneumocystis carini and TB, and again CMV. And as you know, in HIV, you can have certain malignancies as well, which might give rise to pyrexia of unknown origin. So if you look at the causes for PUO, they can be broadly classified. So one thing that you of note is that most of the time in PUO, it's usually an uncommon presentation of a common disease rather than a rare disease. So most of the time PUOs are generally treatable as well as they are kind of benign. So we don't have to worry most of the time. But the challenge is we should be able to differentiate between what is benign and what can potentially be harmful and can potentially kill the patient. So we can broadly classify the causes as infectious and non-infectious. Most of the time you will be dealing with infections. They could be viruses, bacteria, fungi, or parasites. Then when it comes to non-infectious causes, you might be dealing with autoimmune diseases, malignancies, certain neurological conditions where the hypothalamus cannot regulate the temperature. Then there's something called drug fever, where when the patient is on lots of antibiotics, that itself can give rise to fever. Then there are endocrine disorders such as thyroiditis. Then of course, time to time we might find factitious or iatrogenic fevers. So this table gives more details, and these are kind of the common scenarios that you might encounter. So when it comes to infections like bacteria such as Salmonella, tuberculosis, Mycoplasma, infective endocarditis, osteomyelitis. Then common viruses would be EBV or CMV. Then parasites like malaria, we don't see it anymore in Sri Lanka, but we still have to be aware of, because time to time you get malaria patients. Then and in pediatric practice, we see a lot of autoimmune conditions also, such as Sogia, SLE, vasculitis. And then of course, you should never forget about malignancies, especially leukemias, lymphomas, and certain solid organ tumors such as neuroblastoma. Then there's a group of disorders called the great imitators or the great masqueraders. So these are the diseases that can present as anything. I mean, there are there's an old saying that in a ward round, if you see a patient and if you can't come to a diagnosis, always think of tuberculosis, SLE, and malignancy. So these are the great imitators or great masqueraders. Never forget about these conditions when you are dealing with a patient with PUO. So from this point onwards, we will discuss about the rational approach to a patient with PUO. As I said, the most important thing is you should be able to differentiate the dangerous causes that can potentially kill the patient versus benign conditions, right? So with any condition, as you know, I mean, there is this, the traditional approach is history, then you examine the patient, and finally investigation. But when it comes to pyrexia of unknown origin, we can't have this sort of a linear approach. It's going to be more like a circular approach like this. So where you take the history, examine the patient, investigate, and you might have to repeat this cycle over and over until we get a diagnosis. So the important thing when it comes to evaluation is thorough history and examination repeated every day is the mainstay of diagnosis. Simply because you might come up with new information every day when you do the ward round. So that is why it is very important you repeat the history and repeat the examination every day, and then decide on the investigations based on your findings. Literature has shown that about 25% of the signs may be absent on admission, or maybe even absent within the first week. Some classic examples would be this. This is the maculopapular rash, or what we call salmon pink rash of Sogia, systemic onset GIA. So as you know, this is a very transient rash, so it may not be there even more than 1 hour. So you might on one day you might find the rash, on the other day you might not find the rash. Unless you examine the patient for this rash, if you are suspecting Sogia, you might miss it. Another example would be this erythema nodosum, again very transient thing, so you might you might not find it every day, so you will find it in the morning, by afternoon it may disappear. So what are the important points in the history that we must concentrate when evaluating a PUO patient? I won't go into too much detail, but I will highlight the more important points. So we definitely have to ask questions about the fever. It's always important to ask if the fever is documented. As you know, I mean, most patients, they just feel most parents, they feel the patient, and then they decide that it's fever rather than documenting it. And your skin temperature can be altered by the environment temperature, as well as the temperature of the person who's checking the temperature. So it's very important to know if it is documented or not. Then we need to differentiate, is it one illness or is it several illnesses occurring with gaps in between, I mean, which is fairly common, especially among children who are attending nursery. So we call it pseudo PUO, although it appears like a pyrexia of unknown origin, that is fever going on for more than 1 week. It's actually 2 or 3 separate illnesses with the child being well in between. Then of course we need to look at the fever pattern. So as I mentioned earlier, the FUO pseudopyrexia of unknown origin is successive episodes of benign self-limiting infections, mostly viral infections, that may appear like a prolonged fever, but it's actually several illnesses occurring one after the other. So fever diary is very important in these sort of scenarios. So if we ask the parent to document the temperature maybe every 6 hourly, then you can easily see this pattern where you have 3 episodes of 3 days of fever, then the child is well for about 4 days, and again fever appearing after that period, and again settling like that. So these are some of the common fever patterns you might identify. So continuous fever is the temperature doesn't come down at all, it just goes on. So classically we see it in abscesses as well as Kawasaki disease. Remittent fever is the temperature comes down, but it never reaches the baseline. Intermittent is the temperature actually comes down, then goes back again after a period of no temperature. Let's look at some of the examples for these temperature patterns. So intermittent or quotidian. Quotidian means the fever occurring every 24 hours, classic of systemic onset GIA. Then tertian or quartan, that is classically seen in malaria, where the fever occurs every 3rd day or 4th day. Then you have recurrent fevers. There are periodic fever disorders that you might find. One common such periodic fever disorder is FAPA, that is periodic fever, after stomatitis, pharyngitis, and adenopathy. You might see this sort of patient where they complain of recurrent episodes of tonsillitis, high fevers with appearance of lymph nodes, and the treatment is usually steroids. Then classic fever pattern of tuberculosis or B-cell leukemia, lymphomas is where you get evening pyrexia with drenching night sweats. Then the remittent fevers, JIA, endocarditis, and continuous fevers in deep-seated abscesses. So then you come to the systemic review. So you have to ask questions with regard to each and every system: CVS, RS, abdomen, GRT, GUT, joints. Those are. But on general OV, you have to ask about weight loss, night sweats, rashes, lymphadenopathy, which might give you some clues. Then medication history is very important. One thing of note is in Sri Lanka, the paracetamol overdose, that is multiple therapeutic overdoses are fairly common, so you need to ask about paracetamol dose and frequency. Drug allergies are known to present as fevers, and then of course if the patient is on several antibiotics, it might that alone can cause drug-induced fever. Then with regard to past medical history, you have to ask about atopy, autoimmune diseases, and whether there is anything to suggest of recurring serious infections to suggestive of immunodeficiency. Then in the family history, you have to ask about autoimmune diseases as well as immune deficiency. Social history, again, very important, especially travel history, the geographic location, any contact, especially in TB patient, you might get a close contact. Then exposure to animals, pets, and occupation, again important, especially the parents' occupation. And of course, now we'll quickly go through the examination. So general examination, you will have to, as I said, the most important thing is that you have to examine the patient every day, looking for certain clues. So you have to examine the eyes, oral cavity, lymph nodes, hands, skin is very important. And of course, you have to examine all the systems, including a PGAS, to assess the musculoskeletal system, because sometimes these things can be missed if the patient doesn't complain. So we will now look at the investigations. So as I said before, the investigation should depend on what you find in the history and examination. You can't do every investigation under the sun. It's very expensive. So if you evaluate PUO rationally, you have to get clues from the history and examination and then decide on what investigations to do. So as the first line, you will probably do full blood count with a blood picture, ESR, malaria films. Although we have eradicated malaria, as I said, time to time we might get malaria cases. Then C-reactive proteins will be helpful, as well as liver, renal. LDH will be useful to exclude certain malignancies. Blood cultures, generally what we recommend is at least three blood cultures with the height of the fever spike if you want to grow an organism, urine, blood, and of course serology. We would generally do X-ray and ultrasound abdomen to see if there is any septic focus. Then as the second line, you can do more invasive investigations such as bone marrow, lumbar puncture, lymph node biopsies, and of course, more intensive radiological investigations such as CT abdomen. So again, to highlight the most important thing in this part of the lecture, that is the evaluation of pyrexia of unknown origin is a kind of a vicious cycle, a circular pattern where you every day you take history, examination, and investigate, and based on those findings, you again go back to the history, re-examine, re-investigate. I'll give you some examples of my own experience. So this patient is about 4 or 5 at the time when he came. He had fever going on for about 1 week. Unfortunately, he is sleeping when I took the photo. Then, so in the first week, we did a lot of investigation, full blood count, ESR, nothing impressive. This is his X-ray, fairly normal, I would say. Then I think we started on antibiotics also, and we generally give broad spectrum antibiotic to cover whatever that is there in the body. Then on one day we find that, I don't know whether you can see it in this picture, I mean he had cervical lymph nodes. Then we revisited his chest X-ray. We took another chest X-ray, and so this is the very first one, and this was taken after about 1 week. You can see there's a clear difference. There is mediastinal widening. So these are actually hilar lymph nodes, and ultimately what we had to do was we had to take a biopsy from these intrathoracic nodes, and he was diagnosed with lymphoma. So this story just highlights the importance of going through the patient every day and evaluating with necessary investigations. Well, when you look at when you analyze all the pyrexia of unknown origin patients in pediatric practice, unfortunately about 5 to 35% we cannot find a cause. But the good thing is most of them are rather benign causes. Even without treatment they settle on its own. So these are generally not serious. Right. So in the second half of this lecture, what I'm going to do is I'm going to present a case history, and then we will discuss on this case, right? Okay, so this is a case history, I mean, which is not something that you would often see, but it really mimics something that that is fairly common, and then we will move on to the second part of the discussion, right? So I'm going to this patient, about 15 years, 15-year-old boy from a rural area. He presented with low grade fever, fatigue, and he had lost about 2 or 3 kilos of weight. And the fever had been for about 3 weeks. Then in the last week, he has had productive cough, and he was having a progressively worsening headache as well. And on the day he got admitted, so he had been seen by GP and had several courses of antibiotics. But on the day he admitted, he had started having double vision. So that was the main reason for admission. Then when we examined, he had bilateral abdominal nerve palsy, suggesting that there was something going on in the brain. White cells were normal, HB was slightly low, rated again unremarkable, ESR was fairly high. Because of the cough, X-ray was taken. I hope you can see the X-ray. As you can see, there are shadows in the right upper zone with appearance of cavitations. And then MRI brain was done. There were signal intensities around the midbrain area that explains why he had 6 nerve palsy. A lumbar puncture was performed. It didn't have any cells. Then he was initially started on broad spectrum antibiotics, later started on anti-TB drugs also because of the cavitations, the chest signs, as well as CNS signs. TB looked like the obvious diagnosis, but he did not respond. And the sputum for AFB and TB PCRs were negative. So 15 years from a rural area, he initially presented as pyrexia of unknown origin with fever, but later on towards the last week, he developed progressively worsening productive cough and a headache. And on the day of admission, he had bilateral abducens nerve palsy. He had high inflammatory markers, high ESR rather, the full blood count was normal. Then the chest X-ray showed right upper lobe opacities with formation of cavities. MRI showed changes in the midbrain, and LP was negative. He did not respond to broad spectrum antibiotics, and he did not respond to anti-TB treatment, and the sputum for AFB and TB PCR were negative. All right, everybody with me? Okay, hopefully, yes. So then his sputum was sent to a reference lab. The reference lab is actually Faculty of Medicine Colombo lab. They are as far as I know, that is the only place which this test can be done. So the culture actually grew Burkholderia pseudomallei, that is, and the milioidosis antibody titers were also positive. So finally, the diagnosis of milioidosis was made, and in the rest of this lecture, I'll be discussing briefly about milioidosis because it's an emerging illness, and I think all the pediatricians who are practicing should be familiar, at least familiar with the disease, the way it can present, as well as the possible treatment options. So milioidosis is, I think there was a lot of interest in milioidosis over the past 2-3 years, especially there were a few paper articles and a major publication by the Colombo medical faculty. So the bacteria that causes milioidosis is Burkholderia pseudomallei. It's a gram-negative bacteria. It's basically lives in the soil, feeding on dead and dying organic materials. It's an intracellular organism and it's generally a facultative organism. I mean, it doesn't cause disease usually, but if it enters the body of humans, it can cause disease depending on the person's immunity. So it was first described in 1912, almost a century ago, by Alfred Whitmore. He was a major in the English army in Burma. Then what he identified was that this disease. So he identified the bacteria. He knew that it was a bacteria, as well as he described the condition by autopsies, and he also found that this disease was spread by skin inoculation, by prick injuries. So another interesting thing that happened was this paper, which was published, I can't remember the journal, but once it was published, it was read by Sir Arthur Conan Doyle, and this was the inspiration for his short story, which was published the year later, called The Dying Detective, where Sherlock Holmes receives a box with a pin, and then it can actually get an organism inside, causing disease. So although it was not named as milioidosis, it's a different name, but the disease was actually supposed to be milioidosis because he had actually read the paper in the previous year. Then the first case in Sri Lanka was described in 1927 in a British tea trader, and in fact Sri Lanka was the third country to ever describe this condition. So we were among the very first countries to report milioidosis, but for some odd reason it was not described for a long time till maybe in the 21st century when the interest was renewed. Then it was kind of the talk of the town in the 1970s, or even after that, when the American during the Vietnam War, when the Americans were fighting in Vietnam, they found lots of helicopter crew members were getting this infection, and they later on they found that this organism was living in the soil. So when the helicopters were landing, the rotors kind of raised the dust up, and the people were aspirating the dust and then getting the disease. So initially they thought that it was they realized that the disease was spread by direct inoculation through the skin. Later, after this incident, they found that it was the aspiration also resulted in the disease. They named this disease as time bomb disease because there was a long incubation period. So the war ended in 1970, but some of the soldiers who returned, even after a decade or two also, they developed this condition. So that's why it was called the time bomb disease. Then during the tsunami in Thailand, there was a cluster of patients, and what they found was that when they investigated these cases, they found that the water was contaminated by the bacteria during the tsunami, and this got aspirated and causing the disease. So they found a third method of getting the illness, that is by aspiration. So this is called, so this map shows where it is mostly seen. As you can see, it is seen mostly in the tropics. So there's something called milioidosis belt, that is 20 degrees up and down the equator. Sri Lanka definitely is in that belt, but it is hyper endemic in countries like Thailand, northern part of Australia. So when it comes to milioidosis situation in Sri Lanka, as I said, the first case was seen very early in 1927. Then there was a long hiatus where the disease was not described, but now it is thought it is becoming endemic because we are seeing more and more patients. Then in between 2006 and 2017, they had found that there were about 250 culture positive cases. Remember, these are culture positive cases, so we might actually be missing certain cases also. And out of that 250, 10 had been school children, and the youngest had been 2 years. So it is there in children, although it is more commonly adults. So as I said, it's probably undiagnosed. So if you look at the incidence pattern and the mortality, so what is seen marked in blue is the number of patients detected in each year from 2006 to 2017, and what is labeled orange is the number of patients who had died. As you can see, I mean, almost 1/3 to about 20 to 30% patients had died. So which shows that it's a fairly fatal illness. But Professor Inoka Korea, who did a lot of, who has done a lot of work on milioidosis, believes that it is the main reason why there is such an increased fatality rate is because lack of awareness among healthcare workers and not thinking about milioidosis when such cases occur. So that there is delayed diagnosis. So the transmission, as we discussed in the history, so it is the number one would be percutaneous inoculation through a skin wound or a prick injury, then inhalation, then aspiration during the tsunami, and also rarely injection also can cause the disease. Is there human-to-human transmission? What they have found is in patients with lung milioidosis, when they cough out lots, there's a very high number of bacteria which can potentially infect another human being, but luckily it is not. It is very, very rare. And also they have found even vertical transmission, not exactly vertical, transmission from mother to baby when the mother has milioidosis abscess in the breast. So that also has been reported, and some very rarely they have shown that it can be spread by animals also. And of course lab staff are also at risk because they might inhale these particles and get the disease. So this is a potential bioweapon, right? So there are, at least in the adult population, there are clear risk factors for very serious disease such as diabetes, chronic kidney disease, chronic lung disease, and any form of immune deficiency. And in Sri Lanka especially, they found alcoholism was also associated with very serious disease resulting in death. But this doesn't mean that healthy individuals cannot get fulminant disease. So even healthy person without any background illness can have very severe illness. At least, and also according to the statistics, in children they haven't really identified any major risk factor, right? So let's briefly look at the clinical features. The incubation period is generally considered as 1 to 21 days, but there are reported cases where the incubation period can be as long as 30 years. So the longest incubation period had been 30 years. That is somebody who had gone to Thailand 30 years ago and then developed the illness after that. So there are three types of presentation that you might get: acute infection, where the patient presents with fever, sepsis, severe pneumonia, and ending up with death. Then there's chronic presentation, like insidious onset, where there is the patient can present as PUO, gradual onset cough, just like TB, right? The case that we discussed earlier. Then of course there's latent disease, where the patient is fine as long as his immunity is there, but later on can have reactivations, just like TB. So the acute infection is generally defined as symptoms of less than 2 months duration. They usually present as either septic shock or severe pneumonia, but there can be other presentations also, but these are the two commonest ways the patient can present in the acute stage. Chronic infections can, that is symptoms going on for more than 2 months before a diagnosis is made. They generally present as chronic pneumonia, just like TB. Also they can present as skin ulcers, abscesses. And of course, as I mentioned, latent infections can be there for decades and decades before the patient becomes symptomatic. So these are the common clinical manifestations. In the acute stage, they can present as septic shock, pneumonia. They can present as soft tissue abscesses, that is superficial abscesses, as well as deep abscesses. Sometimes you can have a genitourinary presentation like dysuria, fever, osteomyelitis, septic arthritis, and of course they can have cranial nerve palsy because there is some form of a midbrain encephalitis which result in cranial nerve palsies. So in children, mostly what you see is the cutaneous form, majority. Then of course some can present as pneumonia and bacteremia. So pneumonia in the acute stage they can present like just like any bacterial pneumonia with high fever, chills, rigors, and with respiratory distress. In the chronic stage, it can present like a TB with a gradual onset of cough, productive sputum, night sweats, hemoptysis. So this is the X-ray. This is an X-ray of an acute stage where it presents as a left upper zone pneumonia within a very short period of time. Then this is the chronic stage, which we saw this X-ray earlier with cavity formation, and of course there is some form of fibrosis as well. Then, as I said, it can present as skin ulcers or abscesses with as a result of direct inoculation. So these are some of the skin lesions that you might find. Then sometimes it can present like a UTI, and of course the worst form can be like osteoarthritis or osteomyelitis rather, osteomyelitis or septic arthritis with a chronic discharging sinus from the bone. And it can present as encephalitis. This is the same MRI that we saw earlier. So you can have motor neuron palsy, cerebellar signs, cranial nerve palsies, and sometimes even it can present like a flaccid paresis. Then there can be deep abscesses such as liver abscesses, splenic abscesses, then sometimes renal abscesses. So when it comes to diagnosis, the mainstay of diagnosis is taking an appropriate sample from the site of infection and growing it in a special media. So this sort of thing needs not only special media, but you need experts to make the diagnosis. So because now of course in Colombo Medical Faculty they do molecular diagnosis on the culture samples. So unless you have a specialist like this, it's very difficult to diagnose from cultures. So you can take any sample, blood, sputum, urine, or even skin swabs. Then if you look under the microscope, you will find gram-negative bacilli, especially from the abscesses, like this. You can see the bacillus. But the common thing that most people are familiar with would be serology, but there's a small problem with serology, that is especially if the area is endemic, countries like Thailand or Northern Australia, where people are exposed to this bacteria, the antibodies may be there, so it may be false positive. At the same time, they have found that when the patient presents as acute sepsis, maybe you are looking at IgG antibodies, so these antibodies may not be there. So serology is not superior to culture. And imaging is helpful, it's supportive. We saw how the X-ray changes, as well as CT abdomen findings showing abscesses, as well as MRI brain changes, but they are only supportive, so we can't really diagnose the condition, but it's only supportive. The treatment is, when it comes to treatment, the most important thing is that this organism is resistant to most of the conventional antibiotics that we use in the management of PUO. We generally, when a patient is having high fever going on for weeks and weeks, we start off with cephalosporins such as cefotaxime, cefuroxime, ceftriaxone. These are generally resistant. Although they are gram-negative, they are resistant to quinolones, that is something like ciprofloxacin or gentamicin, penicillin. So it's a fairly resistant organism. So as you can see, I mean, if we do not identify this bacteria quickly, the patient might die, because the bacteria can grow despite giving broad spectrum antibiotics. So these are the usual treatment options. So we can give ceftazidime, just like Pseudomonas, you can give ceftazidime. Carbapenems, that is meropenem, imipenem, those are good. Cotrim is a good antibiotic. Doxycycline again may not be very useful in a septic situation, but again in chronic situations you can give doxycycline. But the main challenge is with treatment. I mean, you have to give weeks and weeks of antibiotic treatment. With treatment, they can develop antibiotic resistance, although they were initially sensitive. That is a big challenge. So when it comes to duration, generally minimum of 2 weeks of IV antibiotics, but depending on the site of infection, you might give a prolonged treatment. For example, if it's a deep-seated abscess, you might give 4 weeks. Osteomyelitis, obviously, you need to give a longer period. And if it is a CNF infection, you generally give 8 weeks. So once this acute or intensified treatment is given, you give antibiotics, oral antibiotics, for about 3 months generally. Usually we give cotrim, oral, or doxycycline. That is to eradicate. As you know, the bacteria can survive in the body and then later on reappear, just like tuberculosis. So eradication treatment is also essential after the acute situation is sorted out. So that brings us to the end of the lecture. So few important take-home messages, even if you can't remember all the content. So number one thing, now one would be PUO is usually an uncommon presentation of a common disease, and the purpose of evaluating PUO is to distinguish potentially a killer disease from a relatively benign condition. And the mainstay of diagnosis of PUO is daily history taking and examination and carefully selecting the investigations. And finally, we talked a little bit about milioidosis, and the thing that you need to learn about milioidosis is that it can mimic TB and it needs a high degree of suspicion and a specialized lab to diagnose. So if you have time, I highly recommend these two articles. The first article is a very good article discussing the approach to PUO in children. It might take just 30 to 45 minutes to read. The second one, only if you are interested, it gives a nice account of milioidosis in Sri Lanka. In this article, Professor Correa discussed about the clinical features and certain other historical events with regard to the illness. And thank you. And if you have any question,